Hit the subscribe button or visit us at auau.auanet.org.
Okay, welcome to the American Urological Association's webinar broadcast this evening. Tonight we're going to be discussing the National Medical Student Curriculum Committee presenting a topic entitled The Many Faces of Urology, a Diverse, Dynamic Surgical Subspecialty. Really, the goals of this discussion tonight are to explain the breadth and depth of urology and also to give our attendees introduction to the diverse patient population urologists see and also to the diversity that exists among urologists themselves. And we hope this gives you a little bit of a window into whether or not urology might be the right field for you. I'm Seth Cohen. I work at City of Hope, which is an institution out in Southern California. I'm a urologist now, and I specialize in pelvic medicine and reconstructive surgery. I'll be moderating. I'm going to introduce our esteemed panelists tonight. Dr. Gina Badolato is Assistant Clinical Professor of Urology at Columbia University and directs the Medical Student Education at Columbia for Urology. Dr. Mobin Mirza is Associate Professor and Residency Program Director for Urology at University of Kansas School of Medicine. Dr. Arthur Burnett is the Patrick C. Walsh Professor in Urology at Johns Hopkins Medical Institution and a Director of the Laboratory in Neurourology and also Director of the Sexual Medicine Fellowship Program there. Dr. Christopher Gonzalez is Chairman of the Department of Urology at the University Hospitals in Cleveland, and he's also the Lester Persky Professor and Chair of Case Western Reserve University Urology. Dr. Nurit Rosenblum is Clinical Associate Professor in the Department of Urology at NYU and also a Clinical Associate Professor in the Department of Gynecology, specializing in female urology and pelvic reconstruction. So tonight there is going to be an opportunity to ask questions, time permitting. You can forward those questions by typing them into the box there that you see on your screen. We will keep those questions and then we will answer as many as we can as we get towards the end of the discussion. So let's begin. We're going to start by asking our panelists some questions, and we're going to get their input and hopefully their insights into urology's depth and diversity. So the first question, why did you choose urology over the other surgical subspecialties? And we'll start with Dr. Burnett for this question.
Certainly. Well, glad to give you my thoughts. Urology seemed to fit with my interests. To be a surgeon, I was inspired by a number of mentors who guided me to consider this. I think I had the interest and aptitude to be a surgeon. It was a kind of a special area that fit with my personality and temperament, and I like the topic area. There's various conditions within urology that are medical and surgical. They span a wide range of kind of disease states, and I was just attracted to that. So a combination of all those factors, I think, led me to urology.
Okay, excellent, thank you. And Dr. Gonzalez, what brought you into the surgical subspecialty of urology?
I think a lot of it was the people that I met and the people that I saw when I was in medical school that I really admired what they were doing. I think the work-life balance seemed outstanding. The variety of surgery, from anything from robotic to microscopic to big open cases to laparoscopic, robotic, all those opportunities were there. Reconstruction, which is what I do, is another one. And the research opportunities I thought were outstanding. Some very difficult diseases that we deal with in urology. When you think about the cancers that we deal with, prostate, bladder, kidney cancer, you think about infertility, you think about urinary incontinence, and there's so many opportunities to help patients. So all those things put together is what drove me to the field. And then people ask me, would you do it again today? And the answer is absolutely yes. I wasn't sure what I was really doing at that time, but I think I made a good decision. So.
Wonderful. Yeah, no, it's amazing when you find something you're just passionate about and you can enjoy. Dr. Rosenblum, what about you?
So I would mirror some of what was said. I sort of knew I wanted to be a surgeon. I was looking for something with a good work-life balance and a lot of variety in terms of what could be done. And when I entered urology about 20 years ago, there were very few women in the field, so I thought it might be an interesting niche for a woman. I saw that there was a need when I would, go to clinics as a student, and I saw patients, particularly female patients, that were looking to see a female. So I sort of thought it was a good match for me. And I also wanted to have a relationship with patients. In a lot of surgical fields, the relationship is very short. And I really saw that as I shadowed various urologists and mentors in my own department, they really had long-term relationships with patients. And that really appealed to me as a unique opportunity in a surgical subspecialty.
Excellent. Yeah, very different from some of the other surgical specialties that we work with as colleagues. Dr. Mirza, what about you? What brought you to urology?
It was a myriad of things. I had the opportunity as a high school student to do some research work with Dr. Smith, who was at that time the chief of urology at the University of New Mexico. Without any intention of going into the field, I got to shadow him in clinics at that time. For a high school student, this was just an amazing experience. You know, the thing that attracted me to urology was attractive enough that I went to medical school solely to become a urologist. I thought, you know, urologists were able to make such a huge difference in their patients' lives. I think it's always very, very amazing. And also, you know, our patients tell us things that they don't even tell their spouse. So we are privy to so many things in their lives, and to be able to make a difference to improve their quality and quantity of life, it's an amazing honor. That's what attracts me mainly to urology.
Excellent. Yeah, so mentorship and field itself both were involved in your case. And Dr. Badalato, what brought you to urology?
Yeah, it's a combination of what's already been mentioned. I was fortunate enough to have urology as a required clerkship during the course of my major clinical year in medical school, which is pretty unique. I have to say I probably wouldn't have even considered the field as a woman, and some of the preconceptions people may have with what urology means as being a field that may be concentrated on just male sexual health issues. But having done the clerkship and have interacted with several residents and faculty members, finding mentors within the department, and really seeing the breadth, as what Dr. Gonzalez was mentioning, of the field that deals with female urology, oncology, pediatric urology, reconstruction. There's really something for everyone. And the fact that it's this mix of medicine and surgery, and the fact that you can build these long-term relationships and valuable relationships with patients regarding, you know, sensitive aspects of their life is really unique to urology.
Yeah, it's really hard to think of another discipline that really truly brings together medicine and surgery so well. I mean, it's really quite amazing. We're going to move on to the next question. Did being underrepresented among your urology colleagues impact your career choices? We've kind of already started this discussion a little bit, so we're going to jump right back to Dr. Rosenblum regarding her experience with that.
Yeah, so, you know, being a woman at the time in urology was a little bit unique. I think that's a little different today. We're seeing more and more women residents and more women medical students who are applying to urology. So I think eventually it's going to be probably a more even playing field. But when I entered, it was a unique aspect for me to be a female. And I think, it sort of made me feel that it was a good niche because I was unique in that regard, and maybe I could offer patients something a little different. So I think I always saw it as an advantage and something that really helped me throughout my career. I did end up choosing to go into female pelvic medicine, or what used to be called female urology, although I have many, many female colleagues in the field who didn't feel that they needed to necessarily practice only female urology and chose to go into other subspecialties within our field. For me, it was a good niche, and I felt that I could help women and give back to women's health.
Excellent, excellent. Dr. Burnett, what about your experience? Underrepresented, has that impacted your career choices?
Yes, I think it did. I did recognize early that there were some neurologic diseases that I did recognize disproportionately affected the African American community, including prostate cancer in particular. And so seeing a need to address that, to perhaps be involved in the medicine, the surgery, the research in the field, which I've been able to do over the years, I think has certainly been a factor that it had impacted my decision to go in the field. And I do believe I've been able to create some impact. And I think that's been what's been rewarding about the field, to recognize that and be able to execute in such a way that I believe that impact has been fulfilled.
Yeah, no doubt, to give back to the community that you're aspiring to see to help. And Dr. Gonzalez, what about you? Being underrepresented, does that impact your career choices in any way?
Yes, it did. I think that, again, just to reiterate what you said about giving back. So I did spend some time in the Army, and we had a chance to go down to South America and places like that, and I was able to just practice medicine. So I told myself, someday, whatever specialty I get involved with, I'd like to give back. So, we would do a lot of trips down to Mexico is one of the places that we went, Honduras, other places in Central America where we would do urethroplasties and stricture repair for these folks. And I think that was one way to give back. And also spending over 20 years in Chicago, engaging with the Latino community was also something very important for prostate cancer screening. We got a pretty big grant at Northwestern, and part of the grant was how are we screening in those particular communities, so they helped me lead that up. So there's an opportunity to give back on those two levels, and I'm very happy that I did it, and I continue to do those things. So,
excellent. That's wonderful. What about you, Dr. Mirza? Being underrepresented, how has that impacted your career choices?
So as the rest of the panelists have mentioned, it's only impacted me in a very positive way. Just to give the listeners some context, I come from an immigrant family. I was a very young boy when my family migrated from Pakistan to the United States. I did not know how to speak English. English is a second language to me. I had wonderful teachers throughout my life, and including in medical school and in my residency. Everybody was always encouraging. I think urology is special in this way. We think of surgical specialties or surgery as really hierarchical and really disruptive at times, but urology is really, urologists in general respect merit, respect hard work, and I never had any of my teachers or mentors ever tell me that there's something I couldn't do, and I've been able to use their support and their trust to forward what I feel like has so far been a good and fulfilling career for myself.
Excellent. And what about you, Dr. Badolato? Has the underrepresented impacted your career choice?
I agree with everything that Dr. Rosenblum had mentioned in terms of being a woman in urology and how that kind of draws other women into your practice just by virtue of them being potentially more comfortable with that relationship. And that doesn't just pertain to issues with female urology, incontinence, and reconstruction, but within any domain of urology, stone disease, oncology, it's just a different relationship, and depending on the patient's preference, they might have, maybe seeking another woman to discuss some of these issues with. Even though it seems that this may be changing in the near future, it seems that a quarter of the people that matched last year, at least in the 2017 match, were women. So many more women are coming into the field, and we may see the demographics of our field changing over time as more and more of these residents graduate and come into practice.
Yeah, that's excellent. I'm hearing some themes come out within urology when it comes to underrepresentation, and that's been our esteemed panelists have been able to turn underrepresentation into an advantage. They've been able to give back to their communities of choice with their expertise, and they found acceptance within the urology community. And if I just want to point out, if you look at the pictures of all our wonderful discussants here, everybody comes from a very different background, and everybody has found success and acceptance and has been able to really make a difference in the care of patients' lives. And they've found a lot of satisfaction doing it, which is, I think, just speaks volumes for the field of urology and for the type of people that go into urology in general. And so we'll keep going here. Okay, next question. At any point in your urological career, have you been made to feel uncomfortable by patients or colleagues because of your background? And if so, how have you managed that? And we ask this question for our attendees so they can hear honest answers if there's ever been any concerns. And so let's start with Dr. Mirza with this question.
So before I answer the rare time that I have been made to feel uncomfortable, I want to say that overwhelmingly I feel very comfortable, both with my colleagues and with my patients. My colleagues respect me, love me, and as do my patients. There are times, and this has happened to me twice in my career, where a patient felt like my religious beliefs, even though I don't sort of outwardly carry them, were not of their liking, and as a result, they didn't want to receive care from me. One of them used some choice words with me, and that's okay. I think the best way to manage that is to sort of just walk away from it and know that that's a rare experience. And I think anybody who deals with patients can understand that patients can be under a lot of stress. I mean, people are under a lot of stress. They can say things that they may not mean 10 minutes later. So I think those are rare instances, and they get shadowed overwhelmingly by positive feedback from patients and colleagues.
Excellent answer. And Dr. Badalato, what about you? Have you ever been made to feel uncomfortable by patients or colleagues?
I agree with everything Dr. Mirza said, that these are very rare instances. Never by colleagues. Colleagues have always been overwhelmingly accepting of having diverse faculty, diverse people to work with. I can think of some instances, particularly during my residency training, when I might have been the only resident on call at nighttime and called to the ER. I can think of one particular case. There was a teenage boy who came in with testicular torsion, which is a urologic emergency. And he didn't want me to examine him because he was uncomfortable having a woman examine him. He wanted another male doctor. And I had to explain to him that at that time, it was like 2 o'clock in the morning, that I was the only in-house urology resident, and that, I was working with another attending who was going to coming in to do a surgery, but I would be initially examining him. Once I explained this to him, and he saw that I was just another professional, and that this was part of the work that I did, and these are part of the diseases that we treat as urologists. He was overwhelmingly accepting, and after his surgery and during his recovery, he thanked me for taking care of him. So I think, as long as we maintain, I think that just dealing with these situations, explaining if it's appropriate, and showing them our professionalism can kind of overcome some of these barriers. Now that I'm in practice as an attending, patients self-select whether they want to see a female doctor or not. So I encounter those situations pretty rarely nowadays.
Sure. Well, it sounds like you handle that extraordinarily well. And Dr. Burnett, what about you? Have you ever been made to feel uncomfortable by patients or colleagues?
Well, not commonly. I think there have been some rare instances where race, I think, has come into play. I think from colleagues in general, not really at all. I think the urology field is exceptional in terms of its the kind of individuals that are very professional, that are very welcoming, that recognize excellence and quality in what you bring as a physician. So I've not had that in any sort of way. I think patients occasionally sometimes they question me, like, where did I train and my background and this and that. I think that's a rare thing. I think that while this is the real world, I think that the way you cope with it, I think, is to continue to be professional, as was stated by Dr. Badalato, and continue to look after the patient, show excellence, and bring your abilities to bear. A certain level of resilience and self-reliance. It's always key, I think, because we will have these encounters here and there. But overall, I think I would consider that they've been mainly a kind of a positive interaction, just being a urologist and being a good physician. Both the responses I've gotten from patients as well as colleagues.
Great. Dr. Gonzalez, what about you? Have you been ever made to feel uncomfortable by patients or colleagues because of your background?
Yeah, not colleagues. As Dr. Burnett had just mentioned, it's been a very, very professional atmosphere. I'm very, very comfortable with my colleagues and very proud of my colleagues. I think there's a very good collegiality amongst us as urologists. I'd say with patients, it does happen on occasion. I would chalk that up, though, to the vulnerability of the patient coming to see you. They're sick, they're scared, they don't know what to expect. And I think a lot of it just comes out to, with all of our patients, is establishing trust. And I think once you extend your hand, shake their hand, let them know it's going to be okay, and you listen, that's the most important thing to do, is to listen to our patients. I think they start establishing trust, and they start kind of melting back. They will not. They put down their defenses, and they're going to make, okay, I want you to take care of me. So I think that's what it is. So I'm very patient with those folks. But so there might be an off comment sometimes, but at the end of the day, I'll let that go by, and we do what we have to do, which is taking care of them the best we can.
Totally agree. Dr. Rosenblum, what about you? Have you been ever maybe feeling comfortable by your patients or colleagues?
No, I would echo what all of the panelists said. I've largely felt very comfortable in the field. My colleagues have been very welcoming and open and encouraging from the time I was a student and a resident until today. I really have had very rare encounters where I've had a sort of a negative interaction with a patient. I can't really say I've ever been uncomfortable, but of course, as everyone has said, there are rare instances when there might be more of a negative interaction. And really the only time I can even think of such an interaction was more when I was a resident and we were responsible for taking care of some of the male prisoners with urological issues. And if I was a female going up to the prison ward by myself, there were times when you're surrounded by, a large number of male prisoners that some comments can be made that are not so pleasant. But I just maintained a professional attitude and sort of learned to ignore that and focus on what I was there for.
Wonderful. So I think what I'm hearing from all of you is that colleague-wise, it's been fantastic. And there's been a huge amount of collegiality and support within the field of urology, which is reassuring. When it comes to patient care, it sounds like we're hearing that we want to be ambassadors and demonstrate expertise and excellence that can serve the patients and establish trust. And it sounds like you all have overcome perhaps some rare circumstances extraordinarily well. We'll go ahead and move on to the next question. So this is obviously focused to Dr. Badolato and Dr. Rosenblum. And we've answered some of this already, so elaborate as much as you think as needed. Dr. Badolato, how have you navigated being a woman in a male-dominated specialty?
It's been overwhelmingly positive. I was fortunate enough to have several women who were in attending roles in the department which I trained during the course of my residency, and several other women residents who served as mentors and role models for me. And I also had, I think mentorship overall is key towards building your confidence and just supporting the trajectory of your career, whatever that might be. Role modeling and mentorship are key aspects of this. It's not been an upward climb, I have to say. Overwhelmingly, people have been very supportive of having, again, me as a woman in the department and the perspective that I bring. And I've received a lot of support within my department and among my colleagues.
Great. Excellent. So you found some mentorship and support. And Dr. Rosenblum, what about you?
So as I sort of mentioned before, I always felt, I guess, differently that, being a woman was sort of a unique and a positive aspect to being in a male-dominated specialty. So while I was trained primarily by men with some very important female role models, but I learned, obviously most of my practice of urology from men and how to be a good doctor, how to be an excellent surgeon, how to be an all-around good person. I think, we have a lot to learn from each other, and I think women in the field might be a minority, but we might offer something to a male-dominated specialty, like how to be a good listener, how to be empathetic to patients. So I think it's sort of a back-and-forth exchange that's beneficial to both groups in a field that, although is still male-dominated, has always been very welcoming to females in my experience.
Excellent. Excellent. Okay, we'll move on to the next question here. And some of you already posted questions regarding this, so this may answer some of the queries you've already been thinking about. And so we'll start with Dr. Gonzalez with this question. how do you balance taking care of a family and a busy urological practice? How do you make that happen?
I think you set me up for this one. You know I have 5 kids, right? So
well, you know, that's I can see into the future. I understood who I was talking to.
Yeah. No, it's easy because you prioritize, right? So I've got kids all the way from a sophomore in college down to a 6th grader, and it's just extremely important that you prioritize your family first. It has to be that way. It's never your job first. It's always your family first. There's important things that we do. We take care of patients, the most important thing we do, and the other things, research and the committees that we're on and everything, but it's your family first, and I make sure that we carve out the time, and I don't really compromise on that. I think that's important because you don't get those times back. So you're missing somebody's baseball game or somebody's football game, you know, you don't have a chance to go out with your spouse. I mean, I think that's a missed opportunity. So no matter what you're going to, the best advice I always give students is just you prioritize it and make sure it's right there on your calendar. That's what you're going to do, and you're not going to compromise. There's going to be emergencies. There's going to be one-offs where that's not going to happen. But at the end of the day, if you prioritize it and you make it a must-do, then you will balance very well.
Excellent. What about you, Dr. Burnett? How have you found yourself balancing career and family?
Well, I think I have similar comments as Dr. Gonzalez just mentioned. You know, certainly being a physician and a surgeon, but there are going to be a lot of demands. I think we certainly are dedicated to what we do, our patients, and you know, we don't necessarily have a job that's 9 to 5. You know, we have more to what we do than that. But as has been said, I think it's very important to achieve work-life balance, and I think you have to work at it. You know, that's what I do. I mean, I set aside time for activities. Certainly, you create a schedule and you try to adhere to it. There are occasionally situations that arise that sometimes interfere, but I think as mentioned, prioritizing, making sure that you set aside that time. We all need time to decompress, to cool off, and spend time with family and friends, and just do things we love to do. And I think you just have to decide that you want to do that in the midst of just having a hectic lifestyle. I think it's, at least for me being a urologist, has been a very rewarding career to acknowledge that while I have all these demands, I can still do many other things that come with the field as well. But having these other aspects of family and friends and prioritizing and making those fit in, key things to do. I think that's something that we can all can achieve in the field.
Wonderful. Okay, and Dr. Rosenblum, what about you as being a mother? How do you balance taking care of a family in a busy urological practice?
So I think a lot of it echoes what Dr. Gonzalez mentioned. I have 4 children, so I'm not quite as high as he is. But I think prioritizing, as you said, and I think what I try to encourage my female residents and fellows that come to me for advice is just to make sure that you advocate for yourself and what you need as a woman, and not to feel guilty asking your boss or your chairman or your fellowship director if you need a day off or a half day off to go to a doctor's appointment with your child or to attend an important school function. You have to, as everyone said, prioritize, and just, I think as women, we tend to feel more guilty and maybe don't advocate as well as our male colleagues. So I think it's just important to remember to advocate for yourself and make sure that you're clear about what's important to you. The nice thing about urology, I think it's probably pretty obvious, we don't have a huge number of surgical emergencies. So as a surgical subspecialty, I do think it is a little bit easier to have a very reasonable work-life balance compared to some of the other surgical subspecialties. And I think it's apparent just from the diversity of our panel and what we've all stated that, you know, most of us feel very comfortable in our field choice and are able to maintain that balance.
Wonderful. Dr. Mirza, anything to add?
Yeah, I think most good things have been said. What I would add or just articulate differently is I think the key to having a work-life balance is having good support, whether that's from a spouse, whether that's from colleagues, you know, whether that's from your assistants, from your nurse, whoever's working with you. What the whole apparatus has to support you. And I'm fortunate. I'm grateful to God. I have that setup, and I'm surrounded by people who are continually supporting me. and I'm able to do the things that I want to do, whether that's coaching my kids' baseball team, whether that's going to the jiu-jitsu practice, and running a reasonably clinically busy practice, doing research, doing educational work. I think it's very doable, and I think within urology, it's supported. I think people are looking out for you.
That's fantastic. Dr. Bottolato, anything to add to what we've discussed?
I agree with everything that's been said. I think just, again, knowing your priorities, knowing up front how you want to structure your day and structure your time is very important, and coordinating that with your boss and verbalizing that is key. You don't want to you want to manage expectations. So you want to be upfront. This is what I want my work schedule to look like. This is, when I want to be in the operating room. This is the days that I'll be in clinic. You want to have that laid out very clearly, and you want to lay out the timeline of how many, what your day is like. If that means you want to be home in time, for your kids' soccer game or to see them come home from school, you want to have that kind of built into the template that you've agreed to or signed on for when you accept a position. And as Dr. Rosenbaum was saying, really advocate for your needs as you see them, and have that be an implicit part of your as you're onboarding as a faculty member.
Yeah, I mean, this is all just fabulous input, and I think what we're taking away from it. Number one, I think for the attendees, you need to understand the panelists you see before you are all extremely successful, accomplished, dual threat people, triple threat people doing research, academics, teaching, and they're telling you you can do it. I mean, that should say something. In addition, they're kind of telling you that you need to carve out time and prioritize. You need to advocate for what you need to make yourself happy. Don't be afraid to do that. And you need support. You need a support system. But certainly within urology, there's opportunity to perhaps do it all, dare we say. Okay, so we're getting a lot of good questions here. So over the next course of our next questions, we're probably not going to get answers from everybody. We have a lot of people listening. I encourage you to forward your questions along, because we're gonna save some time at the end to try to answer those questions for you. So if you have any burning questions, please write them, send them over, because we're getting a list here and we're going to try to answer some of those. Okay, let's go on to our next question. Okay, can you describe your patient population in terms of gender and age? Dr. Burnett, can you describe your patient population in terms of gender and age for us?
Sure. In terms of patient population, it reflects where I have tended to specialize over the years. I do cancer surgery and cancer disease states in the public area, reconstruction, as well as sexual medicine. So with that, it fits with a population that tends to be somewhat older, 50s, 60s, 70s, let's say. In terms of age, it can be men and women, although predominantly men, because of sexual medicine and that sort of thing. Having been here at Hopkins many years, Johns Hopkins, we do a lot of prostate cancer sort of specialty area, so I do a lot of surgery and a lot of activity in that realm. So there's men with that, but do encounter families and spouses and things of that sort as those situations arise. So know that I interact with many diverse population. So it's not just older men. It's a range of people actually.
Got it. And Dr. Rosenblum, can you describe your population for us?
Sure. Because I'm subspecialized in female pelvic medicine, I would say about 90% of my patients are females, about 10% male. And the age range really spans the entire adult population. I really don't do pediatrics, although I will occasionally see sort of late adolescent teenagers. I definitely help to transition some of the pediatric patients when they do become young adults, so I will see them as young adults, mostly females. But it really spans the whole age from early adulthood until end of life, so pretty wide spectrum.
Wonderful. And Dr. Gonzalez, what about you? What type of patient population do you see?
I see anywhere from adolescents all the way to octogenarians. So it's male reconstructive surgery, erectile dysfunction, penile prostheses, and urinary incontinence as cancer survivorship of folks who have some problems after their cancer surgery or radiation. So generally it's going to be men. 95% of my patient population is men with those particular conditions.
So I would challenge our medical students listening to find another field that has so much breadth and diversity in the patient populations they can treat. I think it's going to be extremely challenging for you. Urology stands out as a specialty that can allow you to choose what your interests are, and really, if there is a group you want to focus on, you can do that. Okay, the next question. Has the culture of urology changed over the last 10 to 15 years? If so, how? So we're going to go back to Dr. Gonzalez with this question, because I think he's been in the thick, especially with some education with students and being a chair of a department recently. Have you seen the culture of urology change over the last 10 to 15 years, Dr. Gonzalez?
Yes, I have, and I think it's changing in a very positive way. Not that there's anything wrong with the culture before, but I think right now there is a real push for diversity and to incorporate women into the field. I mean, this is something that has been lacking in years past. It's something I think we're all realizing. I do work with the American Neurological Association on things like physician burnout, and we do things on work-life balance, and we look at surveys of our workforce, and we find that the number of women in our workforce is increasing, which is outstanding. The number of underrepresented minorities, you've got a little ways to go on that, and we're working very hard on that, on ways that we can start engaging folks right down to the medical school level, and how do we get them engaged in urology. We really want urologists to be able to mirror our patients, and that's what we're striving, that's what we're pushing for right now. So the culture's changed very positively, and I can say right now in my program of 18 residents, over half are women. So I mean, this is something that's very happy. It makes me happy. It's obviously something that we recruit for very heavily. So
great. And let's so Dr. Mirza, I know you're young in your career, kind of like me, but do you have any kind of perception over the last 10 years or so how you think you've seen urology change or surgery change in general?
Yeah, I think urology is ahead in the change that is happening in surgical fields in general. If we talk to our mentors who trained, much farther along than us, what we find is that surgery in general, and as I was saying this before, was a hierarchical specialty. You're looking at people with high self-worth, where we're looking at people who maybe didn't tolerate flexibility, and I think you still see some of those aspects in other surgical specialties, but very little in urology. Urologists tend to be funny, happy people. People gravitate towards urologists, whether that's in the operating room, in the clinics. We're always having fun. So I think we've adopted that without compromising patient care, without compromising technological advancements in our field. But we've adopted that sort of, we're here for the patient approach, but we don't have to be mean to each other while we're doing it.
Okay, excellent. Dr. Burnett, you've been involved with urology for a few years. What about you? Can you see any change in the culture over the last decade or so?
Yes. Well, I guess I've been around for a little while with urology, and certainly believe that it has had some changes. Similar to what's been said, I do think that there has been greater diversity in the field, better acceptance of different backgrounds, diversity of thought, with recognition of all that different individuals can bring to the field in terms of their ability to contribute, ability to help expand the field. I think it's been a very positive thing by all means. I think also, as has been said, that I think surgery in general, but certainly urology perhaps leading the way, has been stated, does reflect an evolution toward a better balance of what we're doing with work-life. I think back when I trained back in the 80s, things were very regimented. I remember coming through residency with the short white coats and the white pants and all these kind of things. Very regimented, a lot of hours, a lot of residency hours, a lot of training, a lot of hard-nosed kind of stuff. And I think that's really changed a great deal with better balance of what's going on professionally and personally, better acceptance. Urology, I think, certainly, as we're all saying here, is very positive in this way. And so for the audience, I think that know that it's kind of gone in a direction I think is very favorable, and I think that should be emphasized.
Wonderful. Well, let's also get Dr. Rosenblum's input. Anything to add to this, Dr. Rosenblum?
So I would add one major thing that I've seen change over my my time period in urology, particularly within my subspecialty of female pelvic medicine, is just a real collaboration with other specialties, particularly OBGYN or urogynecology, which is now merged with us nationally in terms of fellowship training, and just incorporating a broader sense of gynecologic issues, menopausal issues, hormonal issues into caring for women with urological problems. So I think when I entered the field, we sort of focused very in a simpler way on bladder dysfunction, incontinence, and prolapse. And I think now we sort of look at the woman much more on a whole level and really collaborate with our colleagues to provide better care for various issues that can affect women as they age.
Excellent. Okay, we're gonna move on to the next question here. So we're gonna start with Dr. Badalato on this one. Who is the perfect urology candidate in 2018? So I see a number of people listening. Some of you may be thinking about urology. I kind of want to get a sense from our panel. Who do you think, Dr. Badalato, is the perfect candidate?
So I think the perfect candidate has a set of qualities, a set of qualities that are kind of intangible. This is somebody who's hungry to learn, someone who's willing to work hard, someone who has innovative thoughts and ideas that are willing to bring that, to innovate our field. Somebody who is someone who's a good communicator, someone who's empathetic, somebody who's eager to learn. These are all qualities that a perfect candidate would have. But, this person, these people can come from all walks of life. They have different backgrounds that can shape those qualities that they're bringing towards the field. This person doesn't have a face in particular. It's just a set of qualities that come across when you review their application, when you sit down and interview them. And this is what we're looking for to change the future of urology as we continue to recruit with each match cycle.
And what about you, Dr. Mirza, as leading a residency? What are you looking for as the perfect candidate?
So there are a myriad of qualities that make up a good urologist, and some of those are qualities that just generally make up a good physician. And some of those things have already been said. So there's a wonderful poem that I read when I was in high school titled "All I Really Needed to Know I Learned in Kindergarten." And I think all of us should read that poem. It's by an author named Robert Fulghum. And it says simple things like play fair, don't hit people, flush the toilet, live a balanced life, play and work every day, take a nap, watch out for traffic. So, simple things like that just make a healthy, good person, a good empathetic physician, somebody who cares about patients, somebody who cares about community, somebody who wants to be a leader, and I think somebody who's going to be grateful to his or her teachers and mentors for making the sacrifices that they're making to be able to train them in their careers. So I think, and outside of that, smart, good board scores, good grades, hardworking, all the typical things you would say. But the intangible things, the things you learn in kindergarten are the more important things.
Excellent. Dr. Gonzalez, who are you looking for in your training program? Well, who's the perfect candidate?
So real short, someone who's inquisitive, somebody who's very reliable, and somebody who's going to be a team player. Those three things, I think, if you've got those three things, and most people that come interview with us do, then it's usually going to be a good match.
Excellent. Dr. Rosenblum, you work at a very large training program in an academic institution. What do you think? Who do you think is the perfect urology candidate?
So I would pretty much agree with Dr. Gonzalez. We're looking for very similar qualities in medical students who are interested in matching into our program. And I think, on paper, most of our applicants are extremely bright, very successful students. Sometimes I wonder if I would match today myself. I doubt it. But, you know, I think the other thing we look for when they come out and interview with us is we want the person who matches with us to be happy in their training, in order to be successful. I think we all need to be happy and comfortable where we are. So it's sort of a non-written, non-verbal sort of feeling that they're going to match into the culture of our program, and probably every department has a little bit different culture depending on the makeup of the people. So we just want to see somebody who seems to fit in with the personalities of our faculty and our residents, and who's going to be happy and be able to contribute.
Wonderful. Okay, Dr. Burnett, we'll finish this question out with you. You lead a fellowship and involved with Johns Hopkins. Who do you look for as the perfect candidate in 2018?
Well, I think I agree pretty much with what's been said, but I think certainly some of the attributes would have to do with collegiality and teamwork, team player, somebody who is going to work with the team. That always is very, very important. Certainly somebody who's had a track record of contributions and shown that they strive for excellence. I think that kind of is an indicator that somebody's going to continue to do that throughout their career and make some major contributions to the field of urology. Of course, the attributes of a good physician, to care for your patient and have compassion. These sorts of things I think we'd love to see in our urology candidates as well.
Excellent. And so I think our attendees can see, just based on the high quality of our panelists, you know, urology is looking for good people. They're looking for good people, and that has no bounds. So we're going to keep moving on here. We're probably coming towards the end of our questions from our panelists. So let's talk a little bit about the American Urological Association. So the American Urological Association is a fabulous organization. That's the professional organization for urology. And there's a significant opportunity for medical students to get involved. And so you can join and be a member of the AUA as a medical student. I don't believe there's any fee for that, and you get a lot of access to some very interesting educational materials. In addition, there's a fabulous Twitter feed that the American Urological Association has. There's some hashtags on there that are privy for medical students. Every year, there's a national meeting. This year, it is going to be, this upcoming year, I should say, it's going to be in San Francisco. It's the AUA 2018. You're all invited to come. It's an amazing meeting with just an overwhelming amount of fabulous discovery and collegiality. And if you can make it, would encourage you to reach out to the AUA, get involved, become a member, and come to the meeting. In addition, there is the National Medical Student Curriculum Committee, and so that's where this webinar has come from. The National Medical Student Curriculum Committee actually is specifically designed by the AUA to give you, the medical students, an opportunity to further your education regarding urology and to get exposure to it. And so if you go to the American Urological Association website, there actually is our portion of that website, the medical student curriculum portion, that has a great deal of interesting didactics for you, including probably the best video I've ever seen done on the male genital urinary exam. Probably Dr. Mirza and Dr. Badalato can agree to that, because I know they've seen it as well. It's just fabulous. And so I would really encourage you to go through that website. There's also an app, the National Medical Student Curriculum app, that you can download that has some very interesting vignettes that may be educational for you too. So we try to provide you resources and give you opportunities to get exposure and to get educated. I want to talk very briefly about and give you an example of some of the specialty societies that exist within urology, just to give you some more example of the depth and diversity that is recognized and advocated for. So there's the Society of Women in Urology that maybe Dr. Badalato can talk about just for a few moments.
Yeah, so this is our Society for Women in Urology. Each year at the annual AUA meeting, this group holds a dedicated program which includes a lecture series, features some research that has been done by other women residents or faculty members across the country, and also affords a social hour for young women in urology to meet with some of the more established women in urology during their time at the AUA conference. I would encourage everyone just to take a look at the website, Society of Women in Urology. They have some interesting opportunities for you to either nominate a mentor, someone that's been a mentor to a woman who's considering a career in urology, or for those that are residents, there are research and travel grants that are available on the website as well.
Great, thank you very much. There is also the R. Frank Jones Urological Society, which is representative of the largest and oldest national organization for African American physicians in the United States. And this is also a wonderful example of diversity in societies that we have in urology. Okay, so now we're going to go to some questions from the attendees. So if you have questions, please send them in. We're going to answer as many as we can. I'm sorry, go ahead. Anything else? Okay. We have some questions that we're going to be answering from the attendees, and we'll try to get to as many as we can here. So let's start here. Okay, first question to us is, do you feel urology is LGBT friendly? So let's go to Dr. Rosenblum regarding that question. Do you feel urology is LGBT friendly?
I do, and I think it's based on the fact that urologists across the country have taken a real lead in caring for those LGBT patients and also participating in a lot of the transgender work that's being done. We have a very active program at NYU, and many of us throughout the department, no matter what subspecialty we're in, are seeing LGBT patients in New York. So I think because we are easy to talk to in terms of sensitive topics, we probably represent a field in medicine that is uniquely positioned to help deal with those kind of issues.
Okay, great. And next question is, would you be willing to elaborate on the long-term relationships with patients? And so can you describe that a little bit more? Why don't we go to Dr. Gonzalez regarding that question? Can you elaborate on what it means to have long-term relationships in urology with patients?
Yeah, I think it's an outstanding question, and I'll tell you that I've been a urologist now for about 18 years and 6 years as a resident, and I still have folks that will call me when I was a chief resident, when I was first starting out at Northwestern. They'll come to Cleveland, they'll call me, and I think there's a real opportunity for that, because some of the conditions that we could not see that someone is going to be so happy if they can't urinate and they can't pee, and you can fix that, or sexual dysfunction or urinary incontinence. Some of the conditions that we treat can be just awful for patients, and if you fix them, they're your friends forever. And really, that's a special bond, and you really feel like this is exactly why I went into this whole thing, is because to see the joy that these folks have and the loyalty that they have, and it's really a nice thing. So the answer is yes, very good long-term relationship with patients.
Okay, great. This is going to be a question for Dr. Burnett. For someone who's interested in the oncology aspects of urology, is there a different path towards that area than if they were interested in other sides of urology? Do they have to do something differently?
Well, I don't think that necessarily so. I think in urology, yes, we have subspecialty areas that one may kind of gravitate to, particularly as they go through residency and then start to consider what they really want, what that person wants to do as a career endeavor. But early on, certainly we want all trainees to have a breadth of knowledge in all areas of urology. Sometimes you may have an interest and then start to go into something else. And oncology, which is what I do, I also have an interest in survivorship and addressing some of the recovery aspects of dealing with cancers in urology. And so what's interesting about that is you can blend different things sometimes too as you go forward. So I wouldn't necessarily want anybody to early on get pigeonholed, but I think just doing well in urology, taking an interest in getting started in the field, and then letting that develop, and then as you start to identify mentors in some areas of interest, yes, you might start doing some projects to go into oncology, but I certainly wouldn't recommend fast-tracking things too fast now.
Okay, great. This question is going to be for Dr. Badolato. Is research essentially required to be considered competitive to match into a urology residency?
Well, research is just one part of the application in conjunction with your academic record, any other extracurricular activities you've done, letters of recommendation. I would say that, yes, it's required in the sense that we want some evidence that you've developed a question related to, your knowledge of urology. You've worked with closely with another mentor in urology on that question. You've delved into their clinical records, or you've started a basic science protocol, and at least started to ask that question, understand what it means to investigate it. It says more than just getting a paper published in a particular journal. It says 1, that you're inquisitive, 2, that you have a mentor, 3, that you can commit yourself to a project and that you can kind of see it through. Now, that's not to say everybody that's applying has a first author publication in the Journal of Urology. It may mean that you're working on a project and you submitted an abstract, or that you are presenting a poster. It's also a good way to get your foot in the door in the field and come to these meetings and meet other colleagues within the field of urology.
Wonderful. Okay, this is going to be a question back to Dr. Gonzalez because of his reconstruction background. What role, if any, do you see urology playing in trans health? How do you see the specialty evolving to handle this growing population?
I think it's going to take a leading role, and it already has taken a leading role. I know that I've got colleagues that I have one colleague who's a reconstructive urologist who's taken a sabbatical to learn how to do transgender surgery. And I think it's going to be collaboration with our plastic surgery colleagues, our gynecology colleagues, a team-based approach, but certainly with urology and the breadth of training that we receive both from the female and male anatomy and the surgeries that we do, I think we're going to definitely take a lead in this area for sure, and we already have.
Okay, I couldn't agree with you more. That's excellent. Okay, this is a question for Dr. Mirza. So following up on the previous LGBT question, how is the field of urology for a male student who identifies as homosexual? Do you see this being a problem among other colleagues or patients?
The simple answer is it's a welcoming environment for whoever, including LGBT, a gay man. I have 2 gay residents who are men. I have a mentor and colleague who's a gay man, and they are no different than anybody else. I teach all my residents the same, and the faculty treat them all the same. So I don't see it as a barrier. I don't see it as a challenge. I don't think me or any other faculty treat those residents any differently. I care for them just as much as their program director. I teach them just as well. So I see no problem with it.
I think we may have lost Dr. Cohen's sound.
I'm still here. This is Mubin. Anybody else still here?
I'm still here as well, but I don't think we can see the questions, can we?
How about I pick up until he gets back on the line?
Okay, back, yeah.
All
Sorry.
right.
I apologize about that. Technical difficulties. I'm back. Okay, let's keep going. Great. The next question was, let's see here, and this will be for Dr. Rosenblum. What are some of the differences between pediatric urology and general adult urology?
So, generally pediatrics obviously covers the pediatric age range from the fetal aspect. So you do see some women when they're pregnant and are found to have fetal anomalies, and they might be referred to a pediatric urologist so that when the child is born, the baby is born, they can then be followed and any corrective actions taken. And then that spans up until early adult or late adolescence. And I think historically, there have been people in urology that have been advocating for how do we transition pediatric patients who might be born with urological conditions, for example, spina bifida or neurogenic bladder, who require lifelong urologic care and need to then be transitioned from a pediatric urologist to an adult urologist. And there's some discussion also now about having even people who specialize in adolescent urology, just like we have adolescent gynecology. So I think for most of us doing adult work, it really spans the age range from 18 up until end of life, and for pediatrics, as I said, fetal presentation up through early adulthood.
Wonderful, excellent. I'm going to open this to the panel. This is a question that is asking about international volunteering. So there was a mention of international work. Could you elaborate on the international need and breadth of opportunity for urology in the international community? Everyone's had experience internationally.
I can speak
Hello?
to that. Yeah,
Okay, great.
This is Dr. Fernandez. Certainly I think there are great opportunities for them. The AUA, I think, has created a number of opportunities. There are many of us who have recognized the role to do international work. I have personally dedicated some of my efforts to building urology in the Caribbean. I spent a lot of time going down to the Caribbean to work with urology trainees and improving urologic care there. I'm very impressed with what I've gained from those interactions, and I've learned a great deal, and I've learned how to be resourceful, how to show great dedication despite limited resources, things of that sort. So I think it's been a very valuable and positive bidirectional interaction with a number of international opportunities that urologists can get involved with, and even more formally through the AUA.
Excellent, excellent. Why don't we jump back to Dr. Rosenblum? So we have a question that's just asking for, in general, can you describe what's your week like as far as office and surgery ratio? What are your typical hours like?
Sure. So I spend about 2.5 days a week in my office seeing my own private patients in an academic multi-groups setting. I usually start my office hours around 8:30 or 9 o'clock in the morning and end around 5 or 6 p.m. I have a day and a half a week of operating room time. And then I also spend some time a day every other week at our city hospital, which is Bellevue Hospital, teaching residents in the OR as well as in the clinic and supervising. And I'm also involved in a fellowship training program where we train both urologists and OBGYN trained residents in female pelvic medicine. So my week is diverse. Week to week is a little bit different as well. And I think for me that keeps my interest up and makes my career very interesting. I'm very involved in education both at the resident level and the fellow level, in addition to just taking care of patients. So it's been a very rewarding career in that regard.
Excellent, excellent. Why don't we go back to Dr. Mirza? Dr. Mirza, there's a question about what are some of your favorite surgeries to perform? Can you give an example of those?
Boy, I guess it's really difficult to pick, honestly. I'm a urologic oncologist. I do a lot of work in prostate, bladder, kidney cancer. I also do testicular cancer. I think each surgery that I do, from a routine transurethral resection of bladder tumor to something complex like a cable thrombectomy, where we're taking a kidney cancer out along with the tumor that's going into the vena cava, to robotic prostatectomy. I enjoy every aspect of the surgeries that I do. They're all challenging. They have their nuances, their anatomical considerations, and I don't think I can pick one. I really enjoy all of them. Some of them I enjoy because I like teaching those surgeries. So, for example, robotic prostatectomy is one of those surgeries that I really love to teach. It's a challenging surgery to teach. It has many different technical aspects, so I really enjoy teaching that surgery. Something like a cable thrombectomy is a very unique challenge. It requires your skills as a cancer surgeon, as a vascular surgeon, sometimes as a reconstructive surgeon. So all those are taxed and tested. So I enjoy every surgery that I do.
That's a really nice, good description. Let's go to Dr. Bottolato. So this is kind of a thinking out loud question. If you could change one thing about urology, Dr. Bottolato, what would you change?
Oh, that's a hard question, because we're obviously here because we like everything about urology and our career.
We're not throwing you softballs here, Dr. Bottolato. Come on.
Yeah.
I want you to answer the hard questions.
Yeah. I think that, one thing about urology, at least from the application standpoint, is that it's an early match, and that's something that is a challenge for many students, because they have to know early on whether they want to initiate an application into urology, starting their fourth year of medical school. And there's also a challenge for students if they are in a relationship, because there's no such thing as a couples match if you're applying in urology. So I think that the application process is challenging, and unfortunately, I think it may limit some people if they don't have the foresight that they might want to be applying in urology and have, kind of their ducks in a row and are prepared to enter an early match just upon finishing their third year of medical school.
Okay, no, that's a fair assessment. That actually goes back to another question, and maybe we can get Dr. Gonzalez's input on this. Someone was asking is if urology was going to remain a separate early match. Dr. Gonzalez, have you heard of anything otherwise to that if it was not going to be a separate early match?
There has been some pushback at the level of the AMA about urology being an early match, but I don't think it's going to wind up going anywhere. At the House of Delegates, it was discussed, but I think there's enough good reasons to, there's enough good reasons to want to keep it as an early match, I think from the field's perspective. So there has been some talk about it, but I don't think it's got a lot of traction to go anywhere.
Okay. Yeah, no, it sounds like it's going to stay that way. Okay. There was another question regarding whether, and this will be for Dr. Burnett. Dr. Burnett, would enrolling in a master's degree in clinical research benefit a future career for someone who's aspiring to be a urologist, a master's in clinical research?
So doing a master's in clinical research, a formalized training program, I think could be beneficial, but I don't think it's mandatory. Certainly, the urologic field, I think, it reveals, I think, a lot of major contributors to the field who've gone about helping advance the field in a very serious way, which has been tremendous. Some of that has come about through various ways of accomplishment, from formalized master's programs, PhD programs. Some get in the field that way, and then bring a certain background, diverse background, be it in science or engineering or what have you, that then can help transform the field with some innovative new concepts and ways to bring the field forward. So I think there's that opportunity, but again, it's not mandatory. I think that others have done things less formally. I can tell you from my own background that I've run a research laboratory with NIH funding for the past 25 years, and I'm an MD. I didn't actually do a formal PhD or master's training program, but I got involved with research early, got involved with good projects, did have good mentors, and did have the opportunity to really understand science and build it well. So you can see there's a variety of ways that you can make contributions, and it's not entirely required to do something formally, but you can do it, and that's fine. And even with that, you can still get involved with urology and be part of this field.
Okay, excellent. We're going to answer a couple more questions here and then bring the evening to a conclusion. This one will be for Dr. Rosenblum. Dr. Rosenblum, we have an attendee asking if someone could describe briefly why you chose an academic versus a private setting, if you could elaborate on those two different environments a little bit.
Sure. So I chose an academic setting for a couple of reasons. One, I was interested in teaching, and I enjoy interacting with medical students, residents, and fellows, and I thought that would be lacking in a private setting. So a private setting is sort of what you think of more as your community physician, or it could be in an urban environment as well, but someone who's in a practice. Today, I think largely most urologists that are in private practice are in groups. I think it's rare to find somebody in solo practice just because of the changes in medicine in general. Academics are those of us involved in teaching and training. Usually that's going to be at a university-based healthcare system, or at a healthcare system affiliated with a university, where we interact with anywhere from medical students to residents to fellows. And I chose that, as I said, because I was interested in teaching, and I also sort of wanted to have a more subspecialized practice. So being in an academic setting allowed me to sort of focus my area of interest in women's health and women's urology, because I have partners who cover all the other subspecialties. So if I come across a patient with, for example, a kidney tumor or somebody with an elevated PSA, I can refer them to one of my partners and know that they're going to get excellent care, whereas perhaps more of a private practice or community urologist might be a more generalist in some instances where they would take care of more of those problems. And I really was interested in focusing and being more subspecialized.
Excellent. Okay, this is going to be our last question for the evening, and this is really, I think, just going down to the nuts and bolts of how to apply to urology and how do you take that path of training. And so, Dr. Bottolato, if you could answer this, please. One of our attendees is a little confused. They want to know, do you do a general surgery residency first and then choose urology as a fellowship? The answer is no, but could you explain a little bit about the pathway for that?
Sure. If you're interested in applying in urology, you're going to enter the American Urologic Association match. So you're going to apply for the match through the AUA. This occurs in January. You'll get your results as to where you've matched for a program in urology. Once you've matched in urology, then you will enter a separate match for your intern year. You're basically just going to rank the program that you matched in for urology as number one for your general surgical intern year training. And that's going to be through the conventional match that maybe the rest of your colleagues in your class in medical school are matching through. So just to clarify, you're going to match in urology through the AUA match, and then for most programs, you're going to match in general surgery at that program to do your intern year. Very few programs require you to apply for a general surgery internship outside of the program that you're matching in. So you'll do your intern year in general surgery and then spend the rest of the 4 to 5 years of your training in urology afterwards. I hope that answers your question.
And exactly right. And then fellowship specialty training on top of that is subsequent to urology residency. So you do urology residency and then you do a fellowship if you're interested in that, in a specialty like pelvic floor reconstruction or male reconstructive urology or oncology. And so it's a pathway to go through of internship, residency, and then fellowship. I don't want to ignore there's a question about DOs. Certainly DOs go into urology. I don't know if anyone, Dr. Gonzalez, do you have any insight into DOs getting into urology? Is there any special track for them that you're aware of before we kind of bring it to a close, or no?
No, not really. I mean, I think at the end of the day, we're looking for the best qualified candidates, and if it's an MD or a DO, we are more than happy to take a look at the application. Absolutely. So
great. And so some of you are asking the answer to your question, yes, this is recorded, and this will be available for future listening on the National Medical Student Curriculum website. So we hope this has been helpful for you. It is being recorded and will be posted at some point in the coming days. In addition, we want to make you aware there's going to be another webinar that our curriculum committee is hosting. The National Medical Student Curriculum Committee will be hosting a webinar in February of 2018 tentatively. So if you found this helpful, please look out for that. That's going to be specifically on the application process and the match process to get into urology. So be on the lookout for information regarding that, and please sign up. I want to give a big thank you to our amazing panelists, Dr. Bottolato, Dr. Mirza, Dr. Burnett, Dr. Gonzalez, Dr. Rosenblum, who took time from their evening to give us all insight into why they went into urology and their backgrounds. You've been fabulous, and you remain inspirations. I also want to thank our AUA webinar team, Taylor Cohen, who is a medical student, who gave us wonderful feedback regarding the design of this webinar, Jody Donaldson, Mary Pham, Dr. Holbert, our committee chair, and of course the AUA for sponsoring this. So wonderful talking with you all this evening, and we wish you all a wonderful evening. Thank you very much.
Thank you.